Welcome, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I'm the Senior Manager of Clinical and Educational Programs at Osteoporosis Canada. I will be your moderator for today's webinar on rare bone diseases, HPP, XLH, and FOP. Before we begin, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Osteoporosis Canada is the only national organization serving people affected by osteoporosis, working to educate, empower, and support individuals and communities on bone and muscle health and in the risk reduction and treatment of osteoporosis. Our Scientific Advisory Council is made up of experts from across the country in osteoporosis and bone metabolism and is a volunteer membership. Comprised of clinicians, researchers, and educators, the SAC advises our board and staff on scientific and medical issues. OC provides medically accurate information to patients, healthcare providers, and the public. Services include programs and support groups, educational webinars, podcasts, digital tools, and resources available at osteoporosis.ca and community resources. We are excited about today's presentation, which will provide information about rare bone diseases. It is not intended as individualized health advice. If you do have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many as we can in the time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. So without further ado, it is my great pleasure to welcome our speaker today, Dr. Angela Cheung. Angela is a professor of medicine, the Kai and Betty Ho Chair in Integrative Medicine at the University of Toronto, and senior physician scientist at the University Health Network. She is the founding director of the osteoporosis program at University Health Network and the founding director of the Center of Excellence in Skeletal Health Assessment at the University of Toronto. She has won many research awards, teaching and mentorship awards as well over the years, including the 2024 ASBMR Gideon Rodens Mentorship Award. She currently holds a Tier 1 Canada Research Chair in Postmenopausal and Musculoskeletal Health. Dr. Cheung is our past chair of the Scientific Advisory Council at OC. She is a current member of the International Osteoporosis Foundation Council of Scientific Advisors and the President, Board of Directors for the International Society of Clinical Densitometry. She has published over 250 peer-reviewed manuscripts. Her research interests are in postmenopausal osteoporosis, atypical femoral fractures, and rare bone diseases. Please join me in welcoming Angela. Take it away, Angela.
Thank you. And I see there's someone putting their hand up, and I think you can ask questions in the question and answer sort of tab. It should be underneath. There's a Q&A tab, and I already see a question. And the question is, can your daughter view the recording? And yes, I believe it will be posted afterwards. Kerry, can you actually confirm that?
Yes, Angela, all of our webinars are recorded and kept on our website. I think it takes 24 hours for them to be posted, but they will be there.
Great, thank you. So if you have other questions, please post them and welcome. I'm a general internist who have taken an interest, like, 30, 40 years ago in bone. And so I have been working in the bone area for a long time. And so let me just share my slides. Let me just see if I can sort of do this. Do you see my slides? And I'm going to see if I can put it in full screen mode. Do you see my slides?
Yes, Angela, just if you click on full screen, there you go.
Yeah, okay, so great. Okay, so I want to thank Osteoporosis Canada for inviting me to talk today. So this is a public forum, and we are talking about understanding rare bone diseases today. Let me see if I can. All right, like, sorry about that. Technical difficulties, like so. How do I move my slide down? Okay, all right. So these are my disclosures. I have served as a consultant for different companies that have an interest in this rare bone disease area. So just for you to know as well, okay? And specifically Alexion, or what's now AstraZeneca, Ipsen, and Kyowa Kirin. So the prevalence of rare diseases in Canada is about 3 million people. But if we only look at rare bone diseases, it affects about 20,000 people in Canada. And many of these are children. And even though the numbers are not huge, they represent a significant public health concern. And these are often overlooked conditions that impact your quality of life very dramatically. So the session today is really to increase awareness and understanding. So let's go back to the basic. So what are bones made of? So bones are actually made up of collagen fibers, and then minerals like calcium and phosphate gets deposited so that it's a more rigid structure. But it doesn't start like that. It starts at some soft kind of jelly-like tissue, and then minerals get deposited. And usually we think of bone as having two different forms. One is the compact form. So in the diagram here, you can sort of see the thicker white part. If you can see my arrow, this area is what we call compact bone or cortical bone. And then the other area, the middle area, is what was called spongy bone. Now, it looks like a sponge, but it doesn't act like a sponge, meaning you can't really squish it and let it sort of return to a non-flattened kind of form. Sometimes the other term for this area is trabecular bone. And whether it's in the trabecular bone or the cortical bone, or what's known as compact or spongy bone, there's actually bone marrow as well. And so bone marrow is what produces bone cells within the structure. And it produces blood cells. So your red blood cell, your white blood cell, your platelets, and other things. And we often think of, oh, bone as a static thing, but it's not true. Bone tissue actually constantly remodel. So it's kind of like road work. There's digging. There's a team that comes and dig. Those cells are called osteoclasts. And then there's a team that come and fill as well, and those cells are called osteoblasts. I'm sure you've heard of these before, but that's what bone is made up of. So there are many, many types of rare bone diseases, and it would not be possible to go over every single rare bone disease. But I thought I would highlight three of them. So these three rare bone diseases have made a lot of advancement. And so now there are therapies that actually can be more targeted towards the specific bone condition. So I'm going to go from bottom up because it's the more common one. So actually, sorry, the middle one is the more common one. So X-linked hypophosphatemia has to do with low blood phosphorus level or phosphate level with isolated phosphate wasting in the kidneys. And that affects 1 in 25,000 live births. The second one is the one at the bottom. It's a hypophosphatasia. It causes a defective bone mineralization, and it's found in fewer than 1 in 100,000 people. So these are not that common. And then the last one is Fibrodysplasia Ossificans Progressiva. This is when your normal muscle and connective tissue is replaced by bone. And so the bone formation piece is going haywire and making bone everywhere. And it affects 1 in 2 million people. And so in Canada, with about 40 million people, we currently know that there are about 20 or so affected patients with Fibrodysplasia Ossificans Progressiva, which we call in short FOP. And then the next one we call XLH. And the last one we call HPP. So a lot of alphabet soup. So why do people get these things? So the most common cause of rare bone diseases is actually genetic mutations. Sometimes people inherit them from their parents, but sometimes they are spontaneous mutations, meaning you didn't inherit it from your parents, but it's the genes in your body that's not quite right. And so the environmental role, so unlike osteoporosis, the environmental role plays a very limited role in most rare bone disorders. And genetic counseling provides crucial support for affected families. So understanding if someone actually in your family has something like this will help with family planning decisions and other things as well. What are the symptoms and diagnosis? How do you know that you have a rare bone disease? So the common symptoms are bone pain, frequent fractures, or visible deformities. We often use X-rays and CT scans to look at these to see if we can diagnose it with the imaging piece. But we also sometimes will use blood tests to see if we can see any abnormalities as well. The diagnostic journey for rare bone diseases is a long time. Often it takes like 7 or more years, partly because your usual doctor, your family doctor, may not recognize it. And the way to really confirm the diagnosis is genetic testing. So it will confirm the specific disease and also the specific genetic cause as well. I'm going to use 3 cases these are patients of mine, and I would tell you their stories. And hopefully I'll illustrate sort of why we think there's something else going on. So this is a 50-year-old. By the way, I'm choosing woman for today. Rare bone diseases actually affect men as well, but I just happen to have 3 cases that are all women. So this is a 50-year-old woman. I also want to sort of like contrast between them as well. So they're all around the same age. So 50-year-old, this is an Asian postmenopausal woman, pretty healthy, and was on a trip and slipped and fell in the bathroom of the hotel. And so, as you can see on the left is an X-ray. And those of you who have seen X-rays before, this is a hip. So this is the pelvis. This is the ball of the femur that inserts sort of into the pelvis so that you can walk. This is where the fracture is. I don't know if you can see, but it's broken right here. It's a femoral neck fracture. Now, femoral neck hip fracture are pretty common, and they're common for osteoporosis as well. But the usual age for hip fracture, average age, is 75. Yes, there are young people with hip fractures, but usually they tend to be older. And so, having a 50-year-old with a hip fracture, you start to wonder. And so what happened was, we would fix it the same way. We fix with surgery, and we asked the patient, "Do you have any family history of any bone issues?" And she didn't. So when you actually do a bone density test, as you would do one for, osteoporosis, so this is compared to Caucasian normative database. And so when Asians compare to Caucasian, their bone density can be low. And so for this woman who is 50 and postmenopausal, has been postmenopausal for 5 years, you can see that her lumbar spine T-score is negative 3.3, and her femoral neck and total hip T-score were in the osteopenic range or low bone mass range. But the lumbar spine T-score is actually in the osteoporosis range. So, and then we do some blood tests as well. We look at the blood count, look at electrolytes, look at your kidney function, creatinine, and then look at the minerals that is important for bone. So calcium and phosphate. Magnesium is important as well. So we did, for this particular patient, we did calcium, magnesium, phosphate. They were all normal. Then we wonder, what about vitamin D? Well, vitamin D is also normal. B12 is also normal. And I didn't put it down here, but thyroid is also normal. But what you can see is that her CTX, which is the bone resorption marker, it's in the 400 range, 400, 466, which is sort of mid-range for postmenopausal women. But her bone-specific alkaline phosphatase, which is a bone formation marker, is low. So the first test was 10, and then over the years, we have tested her again, and it's 9 and 7, so quite low. And initially, because she had a fracture, her alkaline phosphatase is alkaline phosphate, ALP, alkaline phosphate, is actually normal. But after a few months, it was quite low, 28, and then it bounced around a bit, 40, and then again, quite low, 30 and 32. So then when you see a low alkaline phosphatase, you think about, is there a problem with something called hypophosphatasia or HPP? And so we went ahead with genetic testing of the ALPL gene, and she has a pathogenic variant. So this patient has hypophosphatasia or HPP. Now, I'm going to tell you that right now there are specific therapy. So if she didn't heal well, if a fracture didn't heal well, there are therapies that people can think about. So these are enzyme replacement therapy because the defect is actually not enough enzyme to help with the mineralization of bone. And so the enzyme is called aspartase alpha. And in these specific patients with HPP, it's really important not to use potent anti-resorptive therapies. So those are the bisphosphonates or denosumab or Prolia. And we don't really want to use those medications in this population. Okay, so second case. This is a 51-year-old Caucasian woman with short stature and bowed legs, and was complaining of pain in sort of a little bit below the hip in her thigh. And, this is the height and weight, so she is quite short. And when she walks a bit, she complains of more pain. And so we did an X-ray, and yes, she has had fractures in the leg before, which was fixed by a plate and screws. But you can also see, this is a femur X-ray, that there's this little crack here. Sometimes people call it looser sewn. Sometimes people will say, oh, there's an incomplete fracture. Now, this is different from what we call atypical femur fractures, because atypical femur fractures is on this side, on the lateral side, not the medial side. On the medial side, we think about conditions that cause osteomalacia. So osteomalacia just means soft bones. And so there are many different causes. If someone is low in vitamin D, if someone is low in phosphate, so there are many different reasons why you can have that. But when we see this lesion here, we think of specific conditions. And so what we then do is, again, a bone density test. And, you can see that her lumbar spine T-score is quite low, negative 2.5. Her femoral neck T-score is also quite low, negative 3.5. And her total hip T-score is negative 1.3. So you can say that her bone density, even without those fractures, are in the osteoporosis range. But you have to be careful because someone with osteomalacia on bone density tests will have low bone density as well. So even though the more common thing is osteoporosis, but osteomalacia can give you a low bone density T-score as well. So then we did some blood work on her. Everything is pretty normal except that her phosphate was quite low. So normal is between 8 to 1.4, 0.8 to 1.4, and hers was 0.4. Other tests are quite normal, like the vitamin D is close to 75. B12 was quite normal. PTH is high. So that's parathyroid hormone. And when we look at bone turnover markers like CTX, which is the bone resorption marker, it is quite high. And the bone formation marker, BSAP or BSALP, is also quite normal. And ALP is normal as well. And so we went on to see if she was wasting phosphate in her urine. And so we did a 24-hour urine. We calculated whether she was wasting, and sure enough, she was wasting phosphate in her urine. So this patient, we also sent for genetic testing, and it's testing a specific gene called the FEX gene. And yes, she has a pathogenic variant. And so this patient actually has X-linked hypophosphatemia, or what's called XLH. Now, why is it called X-linked? So it's carried on the X gene. So, if you are male, you would have an X and a Y. If you're female, you would have an X and an X. So if you actually look at sort of what happens, so if the dad carries it, then can only give it to the daughter because the gene that the gene that goes to the son is the Y gene. So the son gets the X gene from the mother. So if a dad carries it, then it's actually the daughter has a chance of getting it. But if the mother carries it, then actually there's a 50-50 chance that the daughter or the son can get it because the mother passed on the X gene to both daughter and son. Now, even though it's mostly inherited from parents, so taking a family history is really important, it can be a mutation that is de novo, meaning both parents didn't have any problem or any issue, but the baby has an abnormality. So that's also possible as well. And right now, there is a monoclonal antibody that is an antibody against FGF23. It's called burosumab that can use to treat these cases. And so what we know is when there's an abnormality in the FEX gene, there's an increased level of FGF23. And so this medication is an antibody against the increased level so that we can decrease it to more normal level so that we can have a more normal phosphate, and the phosphate can be also incorporated into bone as well. Okay, so I'm going to share with you my third case. So my third case is a case of another 50-year-old, 50 or so year old postmenopausal woman. She's Caucasian, and she was feeling very stiff and have flares of red, swollen, painful areas, and currently have a swollen right knee. So you can see this is a radiograph of the right knee. And when you look, you can see there's extra bone. So this piece, I don't know if you can see my white arrow, but this little piece is shouldn't be there. And these pieces shouldn't be there. So this person grows bone. And so when we actually look at her lab tests, they were all normal. But when you do genetic testing for the ACVR1 gene, she does have a pathogenic variant at the R206H level. And so this particular person has Fibrodysplasia Ossificans Progressiva, or FOP. Now, FOP usually affects sort of centrally first before it affects like your hands and arms and legs and those sorts of things. And it goes from the back to the front. And it makes bone in areas that you shouldn't have bone. And so you can see from this photograph that this person has bone protrusions on on the back. And you can also see like rather than just one spine in the middle, there's like bone growth that extends beyond the usual skeleton. Now, so unlike the other two cases, laboratory examination doesn't really yield anything, so blood tests don't really do much. But it is really looking at an abnormal big toe. And so people are born with it. Their toes look like, a little bit shorter, looks like they have a bunion. And even the babies, you can see it. So it's very easy to recognize. And so, often they present with lumps and bumps, painful lumps and bumps, and have a very long workup because people were saying, oh, do they have a tumor or, what is going on? And biopsying these will actually make things worse because it will make the bone growth even more abnormal and grow more aggressively as well. So the way to catch these cases is really look at their feet and think about this. So yes, you can develop bunion if you are, older, but, a kid that is like, a baby or a kid really shouldn't have bunions. And so this is in conjunction with the history, this is a very easy way to recognize this condition. And so there are various, symptomatic treatment that people use, including antihistamines, anti-inflammatory medications, prednisone. Currently, there's one drug that's licensed, is palovarotene, or it's called Sohonos, and there are many investigational compounds trying to treat this condition as well. So in summary, I have sort of highlighted three different cases, one with HPP, one with XLH, and one with FOP. And the first two, you can use blood tests to screen and think about whether the patient has it or not. So it's usually HPP has a low ALP level, whereas XLH has a low phosphate level. But nowadays we actually have very specific targeted treatment. But these are all rare genetic bone diseases. And besides medication, so I mentioned that there are very specific medications for these specific bone conditions. Pain management is important, and physical therapy sometimes will help strengthens the supporting muscles and not in spasms, and also improve mobility and function. And I think the most important piece is really prevent further complications. And often these patients need to be, it's in an interdisciplinary, multidisciplinary kind of team where orthopedic surgeons play a part as well. Because when something is broken or when there are deformities, we need to stabilize the fractures, we need to correct the deformities. And we also want to prevent future breaks as well with supportive hardware. So it often involves a multidisciplinary team and some coordination between different specialists to really have optimal care. And so I want to say that there are quite a few sort of people living with rare bone diseases. And often it's not like osteoporosis. They have, challenges with their daily activities, with limited mobility, which affects their independence. They have chronic pain, which requires management. Sometimes social activities may become difficult. And there are support groups. So Osteoporosis Canada is trying to help in this area as well. There's a Canadian Rare Disease Alliance, so there are sort of various resources depending on the condition. So like I would suggest that you chat with your doctor, your bone specialist about that as well, as there are many different places that you can find support. Mental health is a big issue because a lot of people, almost half the people report feelings of isolation because they have something that's different from other people. They often are anxious, not knowing sort of what the future will bring, and depressed as well. And so, like, teaching folks coping strategies and treating anxiety and depression is actually a piece of that as well. But I would say that there's a lot of hope because as we concentrate on looking at more what we call precision medicine, we are looking at gene therapy. We are looking at a very specific therapies that target the root causes. Knowing what the genetic abnormality is does help us with targeting therapies. And the other piece is we also have these patient registries. And so, like our center is working on a patient registry for HPP and also a patient registry for FOP as well. And because these diseases are rare, we always learn from each other and learn internationally as well from other providers. And so early diagnosis leads to better outcomes. And so I'm hoping this session helps with increasing awareness of these rare and ultra rare bone diseases. And with that, I'm happy to answer any questions.
Well, thanks, Angela. That was great. Lots of great information and a great introduction to learning about these rare bone diseases. We have received a few questions. So we'll start with this one. It is, can any of these rare bone diseases benefit from nutrition and or exercise?
That's a great question. Nutrition is always, everyone can benefit from good nutrition. Eating less junk food and healthy, well-rounded sort of nutrition is important. And I keep telling people that, especially my older population, that protein is important for, muscle and bone. And so that is important for this population as well. For exercises, there are specific sort of concerns for patients. So yes, we do encourage doing whatever is possible. But sometimes, like say for example, FOP, where the patient is like when with minor trauma, even like with vaccination, let's just say, can induce like, abnormal bone growth. And so we don't really want, we need to consider balance sort of the, pros of being involved in, team sports and stuff like that, but also with potential traumatic events. And the traumatic, even minor trauma can cause issues. And so you have to adjust your physical activity and what you do as well. And so in general, we usually teach patients to do more, stretching, more gentle type exercises, and less pounding type exercises as well. I hope that answered your question.
That sounds great to me. It was good information. Thank you. The next question is, do you have any information regarding IV iron-induced hypophosphatemia? The person says she understands it, or he understands it could increase fracture risk.
Iron infusion have various risks, and that's also why when someone has iron deficiency, we suggest that they take their iron orally, take the iron supplement orally. And after the infusion, sometimes when people develop reactions, all your labs are abnormal, not just phosphorus, for a little bit. But then usually it comes back to normal. And with that, it doesn't usually have lasting effects.
Okay. Our next question is, how do the treatments for these rare bone diseases differ from those recommended for osteoporosis?
They are quite different. The usual osteoporosis treatment tend to be trying to slow down bone resorption so that because the most common type of osteoporosis is not the only type, but the most common type is in postmenopausal osteoporosis. And in postmenopausal osteoporosis, there's an imbalance of hormones, female hormones, estrogen. And so there is more resorption than sort of bone building. And so we use anti-resorptive therapies to treat that. And there are other therapies that also induce more resorption. So the most common category of treatment for osteoporosis is using anti-resorptive therapies. Whereas depending on the rare bone condition, that may not be the issue. The issue is not on bone turnover and more resorption and those sorts of things. Sometimes it's a mineralization issue, as in HPP. And so the bone turnover may not be that much affected, but it's really the bone mineralization that there's a defect. And so you really want to target what's wrong and treat it accordingly.
Okay. Thank you, Angela. The next question is, are there any supplements that you would recommend to help support these rare diseases?
I would say no specific supplement. The general recommendation is still true, meaning make sure that you have adequate vitamin D and adequate calcium. We prefer that you have, calcium that's in food rather than in supplements. So those things still hold true. But there are no specific supplement for the three sort of genetic conditions that I mentioned.
Okay. And this will be the last question. Are there any other rare genetic bone diseases that to consider that you didn't cover this evening?
There are many. There are, there's fibrous dysplasia or what's called FD. There is the most common one is osteogenesis imperfecta. And there are many different types of osteogenesis imperfecta. There are Paget's disease, which may be non-genetic. There are many. I think it's impossible to go into every single one of them.
Okay. Well, thank you, Angela. That was terrific. Thank you so much. It was very informative, and I think we all learned a lot about rare bone diseases tonight. For more information on osteoporosis, please visit our website at osteoporosis.ca. I know there were some nutrition questions coming in. You can find nutrition recommendations on our website, as well as a wonderful nutrient calculator. There's a repository of our past webinars. There are podcasts, and there's also upcoming events listed as well if you're interested. And finally, next slide there, please. Finally, if you go to our website, you will find more information about Osteoporosis Canada too, as well as our 2023 clinical practice guideline, which does have information on nutrition for the people that were asking about levels, that sort of thing. So in concluding tonight, I just wanted to say again, thank you to Angela, and thanks to all of you for joining us today, and wishing you a great evening. Thanks again.
Thank you. Thank you for having me.